Welcome to the deep dive. Today, we are really taking a look at safety blueprints. We're drawing from some of the world's most scrutinized, high-risk environments
Mhm.
and applying them directly to the operating theater. Our focus today is really about mastery,
Right.
mastering human factors, team dynamics, and building that systemic resilience to try and eliminate preventable error.
It's such an essential topic. And when you look at the raw data, the sheer scale of avoidable harm in healthcare is, well, it's just untenable, isn't it?
It really
We're
is.
talking about root causes, organizational ones, personal ones, that perhaps surprisingly often have very little to do with actual technical surgical skill.
Yeah, it's not about how well someone holds a scalpel necessarily.
Exactly. It's failures of communication, failures of culture, sometimes failures of cognition.
That is the kind of astonishing truth we really need to face head on. So if your goal, listening to this, is mastery of safety and surgery, well, our mission today is to unpack those hard-won lessons, mainly from aviation, actually,
Yeah.
and systematically explore how understanding human fallibility, our own weaknesses, is now, frankly, just as critical as knowing surgical anatomy itself.
Precisely. We're moving beyond just sort of shrugging and saying, oh, well, humans make mistakes.
Right.
We need to understand why those mistakes happen, particularly within these incredibly complex systems. And maybe more importantly, how elite teams actually mitigate that inherent fallibility.
How do they do it?
Well, they use structured models, proactive steps. We'll explore those models today and hopefully provide some practical, immediate tools you can start using, well, pretty much right away to upgrade your practice.
Okay, let's ground ourselves first in just how big this problem is. When most people think about surgical risk, they tend to focus on, infection rates, maybe technical complications.
Sure, the obvious things.
But the vast majority of harm, it seems, actually stems from system failure.
Yeah, this sort of systemic understanding really hit the mainstream back in 1999. There was a landmark report from the USA Institute of Medicine called To Err is Human.
I remember that. Huge impact.
It was a watershed moment, absolutely.
Yeah.
It identified that errors in surgery were actually second only to medication errors as the most common cause of error-related death.
Second only to med errors. Wow. And the numbers since then, they haven't exactly gotten better, have they?
No, they're terrifying, frankly. Modern estimates suggest that avoidable patient deaths in the U.S. might exceed 400,000 per year.
400,000. That's hard to comprehend.
It puts preventable harm firmly in the top 3 causes of death overall. It's staggering. Even in the UK, where reporting is generally pretty rigorous, the estimates are around 4,000 deaths per year from medical error.
Okay.
And a disproportionate chunk of those comes from surgical or procedural incidents.
And what's really baffling, maybe frustrating is the better word, is this paradox around never events. Things that should absolutely never happen.
Right. Wrong site surgery, leaving a swab inside, the kind of things that seem impossible.
Exactly. And despite having tools like the WHO's surgical safety checklist, which is pretty widespread now,
No.
the incidence of these never events is, worryingly, actually increasing in some places.
That's the key point, isn't it? It tells us we probably have the tools, the checklists, the protocols,
Yeah.
but we're failing at the human level.
Yeah.
The implementation, the culture, the actual use of those tools isn't working as it should.
Okay, so that leads us nicely to the industry that, well, maybe hasn't solved it completely, but has massively reduced this exact problem, aviation.
Mhm.
When we get on a plane, we just expect perfection, don't we?
We do. It's arguably the safest form of travel.
But if you look at the crash data historically, something like over 70% of air accidents weren't due to engine failure or, the hydraulics giving out.
No, overwhelmingly, it was human error.
70%.
That baseline figure is critical. But then, if you drill down even further into that human error component, the analysis starts to show something even more specific. Communication problems.
Ah,
Communication breakdowns potentially account for up to, wait for it, 80% of those human error-related crashes.
80% of the 70%. So a huge chunk.
A massive chunk.
Mm.
And that, I think, was the light bulb moment for the medical field. They saw the parallel.
Okay.
They realized the solution isn't necessarily about making surgeons technically perfect robots. It's about optimizing their performance, yes,
Yeah.
but also building these really robust team dynamics.
And the systems that catch mistakes.
Exactly. Recognizing that, look, humans are fallible, failure is inevitable to some degree, so you absolutely must build systems designed to actively catch those errors before they cascade into disaster.
So the core lesson then, applied to the operating room, is that the most dangerous part of a complex operation might not be the tricky dissection bit,
Right.
but maybe the moment where communication breaks down or someone loses situational awareness.
That's often precisely it. And the systems that aviation developed, things like crew resource management, rigorous checklists, flatter hierarchies where people feel they can speak up, they're now being meticulously, sometimes painstakingly, transplanted into the OR environment.
Because the consequence is the same.
Exactly the same. A communication failure, a loss of awareness. It can lead directly to a preventable fatality, whether you're at 30,000 feet or standing over a patient. Okay, so to really get a handle on this, to achieve that mastery we talked about, you can't just react when something goes wrong. You need a framework, a model, to understand where errors actually come from.
Right. Understand the root causes.
Exactly. And that brings us to James Reason's really influential Swiss cheese model.
Ah, yes, the Swiss cheese model. It's such a great visual, isn't it? Very intuitive. How does that apply in the complex world of the OR?
Well, think of it like this. Each slice of cheese, Swiss cheese with its holes, represents a defense layer, a barrier that's supposed to protect the system.
Okay, like what kind of barrier in a hospital?
Oh, things like adequate staffing levels, clear protocols and procedures, mandatory pre-op briefings, maybe a safety mechanism on a piece of equipment, lots of layers.
Got it.
Now, normally, the holes in each slice and the holes represent latent errors, weaknesses, vulnerabilities. In that layer, they're random. They don't line up.
So the hazard gets stopped by one of the slices.
Exactly. The holes are the system's weak points, the inherent sort of flaws that exist because, well, systems are designed and run by fallible humans, right?
Mm-hmm.
An accident or a major error happens when, just by chance or due to underlying pressures, the holes in multiple slices momentarily align.
Ah, okay, like a clear path through the stack.
Precisely. Creates a direct trajectory for the hazard, whatever it is, to pass straight through all those defenses and result in harm to the patient.
So it's rarely just one single mistake.
Very rarely. The model really emphasizes that errors are almost always the result of multiple factors, a catastrophic alignment failures across different parts of the organization. The final chance to stop it is often eliminating the unsafe act itself, the last hole.
Okay, so the Swiss cheese tells us how failures can align, but what helps us categorize what those failures, those holes actually are? What kind of weaknesses are we talking about?
Good question. And that's where another tool comes in, the Simplified Human Factors Analysis and Classification System, or HFACS.
HFACS.
HFACS gives us a kind of diagnostic framework. It maps those potential failure points, those holes in the cheese, across 4 distinct layers. It starts right up at the highest level, organizational failures, and drills right down to the individual unsafe act at the sharp end.
And the point is to stop blaming individuals.
Exactly. It helps us move away from the blame game, whose fault was it, and start looking at the systemic vulnerabilities that allowed it to happen. Where are the real weaknesses?
Okay, let's break it down. Layer 1. Organizational influences within the hospital. This sounds pretty high level, maybe less about the surgeon and more about the hospital management.
It is. It's entirely about the macro environment, the overall climate, how resources are managed, the established processes. Think about things like financial pressures, administrative targets.
The pressure to hit waiting list targets, maybe? Or keep the clinics running super fast.
Exactly. If there's perceived or real pressure to deliver results, clear waiting lists, push patients through recovery faster, run packed outpatient clinics, maybe even encourage long hours without proper breaks, these pressures inevitably force compromises somewhere down the line.
And how do those compromises actually look? What are the holes at this level?
They become the foundational holes in the cheese. Things like inadequate staffing ratios on wards or in theater, failing to replace old or malfunctioning equipment because of budget constraints, maybe cutting corners on mandatory training time to keep services running.
Right.
A really common example is the pressure to increase theater turnover, get more cases done. That pressure coming from layer 1 might force a team to rush their pre-op briefing. That rushed briefing is a latent failure, a hole that might then align later with, say, poor lighting in the OR, which is a layer 3 factor.
So the organization basically sets the stage for the accident, even if it happens hours or days later.
Precisely. It creates the conditions where errors are more likely.
Okay, moving down. Layer 2. Unsafe supervision. This sounds like where local leadership, maybe the charge nurse or the consultant, fails to manage the risks created by layer 1.
That's a great way to put it. This is a really critical failure point. A major element here is the failure to maintain situational awareness, especially if the supervisor doesn't realize they've lost it or doesn't notice the team has.
Ah, the unrecognized loss of SA.
Yes, supervision also obviously includes failing to adequately train or monitor junior staff. But crucially, layer 2 failures also include things like complacency,
Complacency, how so?
becoming so used to the routine that maybe the briefings get shorter and shorter, or the WHO checklist gets treated like a tick box exercise, just getting through it, rather than a genuine safety conversation.
Right, just going through the motions.
Or maybe the team hasn't actually been drilled on what to do in an unusual emergency. If there's no predefined plan for what if the patient suddenly deteriorates in this specific way? That's fundamentally a supervisory failure. They haven't prepared their team.
What strikes me here is how insidious layer 2 can be. It's not necessarily someone being deliberately negligent, is it? It can be a slow creep.
Exactly. It's often the consultant who's maybe exhausted from working long hours, which is a layer 1 pressure.
Mm-hmm.
And because they're tired, they fail to pick up on the subtle signs that a junior trainee is struggling with a particular step. Or maybe they cut the safety briefing short because they're running late for the next case. Again, possibly due to scheduling pressures from layer 1.
Okay, so layers 1 and 2 set the conditions. Then layer 3 deals with the preconditions to unsafe acts. This sounds like the immediate stuff affecting the person right there and then.
Yes, this is the really messy human side of the equation. HFACS breaks it down into a couple of areas. First, you have environmental factors.
Like the physical or environment.
Exactly. Background noise, loud music, constant chatter just outside the door, alarms going off, poor lighting, even things that seem minor, like the room being too hot or too cold or too humid, making staff uncomfortable. All these distractions chip away at our finite mental reserves. Okay.
And the other part.
The other part is physiological and emotional preconditions. This is about our core human state. Fatigue, obviously, hunger, tiredness, general nutritional status, but also emotional influences.
Like being stressed or upset.
Absolutely. Being angry after a difficult conversation, worried about something at home, stress is a huge factor. Even boredom, interestingly, during a long, seemingly routine part of a procedure can be just as dangerous as panic during a sudden crisis.
Huh. Boredom as a risk factor. That's interesting.
It leads to attention lapses, complacency.
So let's paint a picture. If a surgeon is doing a complex case, the lighting isn't great. Environmental factor. They skipped lunch because the list was overbooked. Layer 1 pressure leading to hunger, a physiological precondition. The system is really primed for failure at this point, isn't it?
The slices of cheese are definitely starting to line up.
Yeah.
And that leads us finally to layer 4, the unsafe acts themselves. This is the final hole in the cheese. It's the action or inaction that directly causes or contributes to the bad outcome.
These are the actual mistakes we tend to hear about. The slip of the knife, the wrong medication.
Yes, but it's crucial to see them as symptoms, not the root cause.
Mm.
Layer 4 acts include things like multitasking, trying to manage an instrument, talk to the anesthetist about blood pressure, and watch the monitor, all at the same time.
Which we all do.
Which we all try to do, often poorly. Other examples are operating outside of one's recognized area of expertise or comfort zone, or, critically, failing to cope with unfamiliarity.
What do you mean by that?
If the procedure suddenly deviates, even slightly, from the normal event, from how it's expected to go, and the team doesn't recognize that deviation or doesn't respond effectively, that failure to adapt is the unsafe act. And it's almost always the direct result of the failures in the prior 3 layers, aligning perfectly to allow that deviation to become a disaster.
Wow. Okay, so understanding these 4 layers, organizational, supervisory, preconditional, and the act itself, that's the key to starting to build genuine systemic resilience.
That's the framework for mastery, yes. It lets you diagnose the vulnerabilities before they align.
Okay, that transition works perfectly. We've gone from the big system picture down to layer 3, the preconditions. And this is where, I guess, aviation spends a lot of time, right? Treating the crew not just as people doing a job, but as high-performance assets that need careful maintenance.
Absolutely. You wouldn't fly a plane that hadn't been properly maintained, fueled, and checked. The same applies to the human operators.
So let's tackle tiredness and concentration limits first, because some of the source material here is, well, pretty shocking when you think about standard medical practice.
Fatigue is, without doubt, the enemy of high performance, especially cognitive performance. In surgery, the data is quite clear. Being tired significantly impairs decision-making, the ability to handle complex mental tasks, and perhaps most critically, situational awareness.
And yet, doctors, nurses, we often wear fatigue like a badge of honor, don't we? Pulling long shifts.
We do. And healthcare professionals consistently, dramatically underestimate how much poor sleep quality or just insufficient sleep degrades their cognitive function. We think we're coping, but the objective measures say otherwise.
Okay, I have to push back a bit here based on the source material. It mentions this idea that intense concentration, like peak focus, can't really be maintained for more than 20 to 30 minutes at a time.
Hmm.
That sounds, well, frankly, impossible for a surgeon in the middle of a 6-hour operation. How can that be right? And how do elite teams possibly manage that limitation?
It sounds impossibly short, I agree, because we routinely push ourselves far, far beyond that limit.
Right.
But basic human neurochemistry concerns it. Our cognitive resources, our ability to maintain that laser focus needed for critical dissection or decision-making, they're finite. After about 20–30 minutes of that peak effort, attention naturally starts to wander, processing slows down, and the risk of fixation error or tunnel vision increases dramatically.
Right.
This is precisely why aviation is so strict about it. They have mandatory flight and duty hour limits. And critically, they mandate that during long flights, one pilot intentionally stays fresher, maybe handles communications or systems monitoring, specifically to be sharp for the most critical phases, like landing or final approach. They take over from the pilot who flew the long, potentially monotonous cruising segment.
So the takeaway for a complex surgical environment isn't stop operating every 20 minutes, but maybe
Mm,
build in intentional moments to reset focus or rotate tasks within the team.
exactly. It requires acknowledging the limitation and designing the workflow around it, instituting intentional short breaks, or having team members explicitly cross-monitor each other for signs of fatigue or waning concentration.
Okay. And beyond just rest, there's the fuel aspect. Physiological performance underpinning, basically. Nutripin and hydration.
Yeah, this seems basic, but it's crucial. If you're even mildly dehydrated, your brain volume actually decreases slightly. Cognitive function, reaction time, decision-making, they all suffer. There's solid data on this. You simply cannot run a high-precision biological machine, which is what a surgeon is, on bad fuel or not enough water.
So what does optimal fuel look like for someone facing a long stretch in the OR? We're not talking about grabbing a quick chocolate bar between cases.
Definitely not. Optimal fuel needs to support sustained focus and endurance, not deliver a sugar spike followed by a crash right when you need peak concentration.
So what then?
We're looking for meals or snacks with sufficient protein, complex carbohydrates, but in moderation, because a big carb load can actually make you feel sluggish mid-procedure, and healthy fats. Things like olive oil, avocado, maybe some oily fish if possible. And importantly, high in vegetable and fiber content. What you absolutely must avoid are simple sugars, highly processed foods, and those unhealthy trans fats. They give you that quick energy burst, but the subsequent drop in focus and energy can be really detrimental, especially during a critical phase.
This all sounds great in theory. Eat well, stay hydrated, rest. But logistically, the source material mentions this idea of taking a 10–15 minute break every 2–3 hours during complex surgery. How on earth does a highly focused team actually do that? Doesn't stopping mid-flow introduce its own risks?
It's a valid concern, but the evidence suggests the risk of not stopping, of pushing through fatigue and cognitive decline, is actually higher.
Okay. So how is it implemented?
It requires planning. It's a supervisory function, layer 2, and needs cultural buy-in from the whole organization, layer 1. The break isn't taken during the most critical minute of the procedure, obviously. It's planned for a relatively stable, non-critical phase, maybe during an instrument changeover, while waiting for pathology results, or during a routine closure phase.
And what happens during the break?
The lead surgeon might step away briefly, hydrate, have that prepared healthy snack, stretch. Crucially, the rest of the team maintains vigilance, and there's always appropriate expertise remaining scrubbed in or immediately available. This short pause isn't just about physical needs. It promotes a fresh perspective, helps reset situational awareness, restores blood sugar, and honestly, it dramatically improves team morale and cohesion. It's a proactive safety intervention, not a disruption.
Right, reframing it as a safety step. Okay. Finally, in this personal factors section, let's talk about emotional status and stress. The idea that we don't just leave our personal lives at the hospital door.
Absolutely not. We bring our whole selves to work, including our emotions. If you're angry about something, worried about a family issue, feeling stressed or under pressure, those powerful emotions don't just vanish when you scrub in. They tend to resurface, especially under high mental workload or when things get tense.
And this can contribute to errors.
Significantly, it increases the likelihood of what the medical field calls a sentinel event.
Define that for us again.
A sentinel event is defined quite precisely. It's an unexpected occurrence involving death, serious physical or psychological injury, or the significant risk thereof. And when you investigate these events, You often find it wasn't purely a technical slip, it was a human being under significant emotional or physiological stress, making a poor decision or missing a critical cue.
Okay.
And to help prevent this collision between stress and performance, the sources introduce a really simple, potentially life-saving self-monitoring tool. It actually originated in aviation safety programs. It's the HL mnemonic.
HLLT. Okay, let's spell this out because this sounds like something every single person on a healthcare team needs to know, not just surgeons.
Absolutely, everyone. HLT is basically a quick mental checklist to assess your own fundamental well-being and critically that of your colleagues, especially before or during high-stakes parts of a procedure or shift. It stands for hungry, anxious or angry, late or lonely, feeling rushed or isolated, and tired.
Hungry, anxious, angry, late, lonely, tired. H.
Exactly. If you recognize any of these factors strongly in yourself, or if you spot a colleague exhibiting signs maybe unusual impatience, poor focus, irritability, snapping at people, it's a clear signal. It's a warning flag.
And what's the recommended action? Just push through?
No, absolutely not. The recommendation is to HLT.
Yeah.
To actually take a brief, clinically safe break to address the underlying need. Get a quick snack, take a few deep breaths, maybe step out for 2 minutes. Acknowledging that you are, say, tired and asking for a brief handover or just stepping back for a moment is far, far safer than pushing through that exhaustion and potentially contributing to a catastrophic error.
So it elevates your personal state, hungry, angry, tired, to the level of a critical risk factor, something that needs active mitigation, just like a technical problem.
Precisely. It's about managing the human element as rigorously as we manage the technical elements. Okay, so we've looked at optimizing the individual in Section 3. Now let's zoom back out a bit and look at how the team and the wider organization manages all these factors. Because ultimately, organizational culture is either the strongest layer of defense in that Swiss cheese model.
Or the biggest, most dangerous hole.
Exactly, and that starts right at the top. Senior management commitment to fostering an open, transparent safety culture is absolutely non-negotiable. It can't just be lip service.
And the consequences when that culture fails, they can be truly devastating. The source material uses the tragic example of the Bristol Pediatric Heart Surgery Service back in the 80s and 90s.
Yes, Bristol.
Yeah.
It's the ultimate cautionary tale, really, of what happens when organizational culture goes badly wrong. This wasn't primarily about technical surgical failure, although there were issues there too. It was fundamentally a failure of Layer 1 and Layer 2 leadership.
What characterized that failure?
The service was described in the inquiry as having unaccountable, quite authoritarian leadership. And critically, there was a profound, pervasive blame culture.
Ah, the blame culture.
Yes, junior staff, nurses, even some junior doctors were reportedly terrified to speak up about known issues regarding surgical standards, decision-making, and patient outcomes. They feared retribution, damage to their careers.
And this silence had consequences.
Direct, fatal consequences. The inquiry concluded that this lack of challenge, this inability for people to voice concerns, directly contributed to an excess of around 35 preventable deaths of children over about a decade.
35 avoidable deaths, linked directly to a cultural problem, not necessarily a lack of skill or basic resources.
That's the horrifying takeaway. The subsequent public inquiry led to sweeping systemic changes across the NHS, but the core lesson was stark. If staff are blamed, shamed, or punished for reporting hazards or near misses, they simply stop reporting.
And when reporting stops?
Learning stops. And the underlying systemic failures, the holes in the cheese that led to those deaths, are allowed to persist, completely unchecked. The lesson is brutal, but simple. Blame culture kills patients.
Which leads directly to a necessary structural reform, flattening the hierarchical gradient. Traditional surgical training and medicine in general often has this very steep, rigid hierarchy, doesn't it? Questioning seniors is often discouraged.
It's deeply ingrained. But in safety-critical fields, that steep hierarchy has proven time and time again to be incredibly dangerous.
How did aviation deal with this?
They learned the hard way, again through analyzing crashes. Early aviation disasters were frequently traced back to situations where junior flight engineers or co-pilots knew something was wrong or had serious concerns, but failed to assert themselves effectively to a dominant, sometimes intimidating captain.
So they changed the rules.
They changed the culture. Now, crew resource management training explicitly mandates that everyone, pilots, cabin crew, maintenance staff, air traffic control, has not just the right, but the obligation to question any safety issue without fear of retribution. It's expected.
Okay, but let me challenge this slightly. In a real emergency, in the OR, say, a code blue situation, or a massive, unexpected bleed, Don't you actually need a strong, clear, almost unquestioned command structure where the lead surgeon takes immediate decisive control? How do you balance that need for rapid command with flattening the hierarchy?
That's the absolute core tension, you're right. And the answer isn't to eliminate hierarchy altogether in a crisis. You do need clear leadership.
Right.
But the overall culture must be flat enough day to day to encourage challenge and speaking up routinely. And critically, roles in a crisis must be predefined.
Ah, okay.
Yeah.
So everyone knows their job before the crisis hits.
Precisely. That way, the command structure is clear when needed, but the underlying culture remains open enough that anyone, regardless of rank, feels empowered to shout, "Stop," or
Yes.
"I think we're missing something," or "We're running out of time here."
And how do you foster that culture practically?
One key practice, explicitly recommended in the sources, is for the lead surgeon or the person leading the procedure to verbally state at the very beginning during the briefing, "Look, I encourage every single one of you in this room, please speak up if you see an error about to be made or if you're worried about anything at all at any point. Your voice is crucial."
Just saying it out loud.
Just saying it out loud.
Yeah.
It's a simple act, but it explicitly dismantles that fear of retribution. It validates everyone's role as a safety monitor.
Okay. So, to manage the flow of all this critical, assertive information, we then need tools, structured communication. Specifically, the briefing and debriefing. We all know about the WHO surgical checklist. It's pretty ubiquitous now. But the source material gives a really serious warning about how it's used or misused.
It does. And it's a warning backed by solid outcome data. The finding is stark. Postoperative patient outcomes are demonstrably worse when only part of the checklist is used.
Worse than not using it at all.
Worse than not using it at all in
Wow.
some studies. It gives a false sense of security, perhaps. The key takeaway is it must be read out fully, point by point, and critically, all team members must verbally participate. Not just listen passively, but actively confirm their checks or state their concerns.
So it's a conversation, not just a script reading.
Exactly. That ensures shared understanding, mutual accountability.
Yeah.
Everyone is actively engaged in that safety moment.
Now, beyond the checklist itself, the sources reference box 2.4, detailing key items for a really thorough briefing. What elevates a briefing from just, okay, introduction's done, knife please, to something truly effective?
A truly effective briefing moves beyond just the basics of introductions and counting instruments. That's baseline. The real value comes from proactive scenario planning. Identifying the major steps of the procedure and who's doing what, yes, that's important. But the high reliability teams consistently discuss the what-if scenarios.
Like contingency planning.
Exactly. Defining roles before an emergency happens. Okay, if the patient has sudden massive bleeding, who is responsible for calling for extra units? Who is suctioning? Who gets the specific clamps ready? Preempting potential failures means that if chaos does hit, the team doesn't waste precious seconds figuring out who is supposed to do what. They react instinctively based on the plan.
Some teams take this even further, right? Asking quite provocative questions.
Yes, some elite teams actually start their pre-case discussion by asking, almost brutally, how could we potentially kill this patient today?
Wow, that's direct.
Deliberately provocative. But the goal is to force the team to intentionally identify the highest risk points of the procedure or the patient's specific vulnerabilities, and then explicitly discuss the mitigation strategies for those risks before they start. It's about anticipating failure.
And then, after the procedure, the debriefing. The structure described focuses on learning, not judging performance.
Precisely. A good debrief is an exercise in continuous process improvement, not an evaluation or critique session. The key questions are things like, what went well today? What should we perhaps do more of next time? What maybe didn't go so well, or what should we do less of? And crucially, what will we do differently next time based on what we learned today?
And the human element.
Never forget the human element. Using the debrief as an opportunity for the leader to sincerely say thank you to the team members, acknowledging their contributions, their hard work, maybe highlighting specific positive actions that fosters a feeling of being valued. And team members who feel valued are much more likely to bring their maximum effort, vigilance, and assertiveness to the next case. It builds psychological safety.
Okay, let's look at another concept borrowed from aviation, the sterile cockpit policy. What is that, and how does it apply in surgery?
The sterile cockpit rule in aviation is very clear. It mandates minimizing noise and strictly limiting conversation only to essential, procedure-related matters during high-risk phases of flight. Traditionally, that's below 10,000 feet, so takeoff, climb, descent, approach, and landing.
The critical phases.
Exactly. Applied to surgery, the idea is similar. It means consciously eliminating non-essential communications during defined critical intervals of the operation.
What counts as non-essential?
Things like chatting about weekend plans, gossip, discussing other patients, taking non-urgent phone calls, loud music maybe. Basically, anything that isn't directly related to the safe conduct of the immediate surgical task.
And when would this apply?
During agreed-upon critical points, maybe skin incision, during the dissection of major vessels or nerves, the placement of critical implants, or during the surgical counts phase just before closure.
Does this policy face resistance? Surgeons, nurses, they often use casual chat to sort of relieve tension or build rapport during long cases, don't they?
It absolutely can face resistance, which is why it's crucial that it's not imposed arbitrarily. It must be discussed and agreed upon by the entire team during the pre-op briefing.
So the team decides together which phases will be sterile.
Yes. Okay, everyone, once we start the anastomosis, let's go sterile cockpit until it's complete. Focus communication only. When it's agreed upon beforehand, it's much more effective. And the evidence does suggest that minimizing these non-essential communications during high-risk moments reduces distraction-related errors. It's not about enforcing total silence. It's about ensuring focused, relevant communication when it matters most.
The consequences of failing to get these team dynamics and communication right are really starkly illustrated by that failure to intubate tragedy mentioned in the source material.
Oh, that case is just heartbreaking because the failure was almost entirely cultural and systemic, not technical inability. You had ancillary staff, junior team members, who were apparently aware that the patient was becoming dangerously hypoxic during multiple failed intubation attempts.
They could see the monitors, presumably.
Presumably. But their reluctance to forcefully assert the need for intervention, maybe call for help earlier, suggests a different approach, like a surgical airway allowed the situation to deteriorate irreversibly. That's a classic hierarchical gradient failure. People were afraid to speak up forcefully to the seniors leading the attempts.
And there were other failures, too.
Yes, compounding that was the apparent lack of a clearly defined leadership role or pre-agreed plan for managing a difficult airway scenario. That points back to a failure in briefing and preparation. And this also connects back to the idea of mental capacity or cognitive bandwidth. A new trainee, for instance, is using vastly more mental energy just to perform the basic motor skills of a task, like intubation.
Right, less spare capacity.
Exactly, which often means they communicate less effectively, or they might miss subtle cues. This is why shared responsibility is so vital. Having nurses or technicians explicitly responsible for tracking and calling out key metrics like oxygen saturation levels, swab counts, estimated blood loss provides crucial backup and redundancy. It distributes the cognitive load.
This brings us nicely to what feels like the final and maybe the most critical non-technical skill of all, situational awareness, SA.
Hugely important.
How we perceive what's going on around us, how we understand the current state, how we project that forward, and how that perception changes or fails to change over time.
Loss of SA is often the point where all the other system failures, the holes in the cheese, finally converge and disaster strikes. Surgeons, in particular, face a very specific risk related to SA. It's often called tunnel vision.
Tunnel vision, like getting fixated on one thing.
Exactly. During long, complex, demanding procedures, it's very easy to become so deeply focused on the immediate task at hand, say, dissecting around a difficult blood vessel or trying to control bleeding from one specific point that you inadvertently filter out everything else.
So you only see things that confirm what you're doing.
You tend to focus only on indicators that relate directly to that micro task, while potentially missing other, sometimes subtle, but compounding problems that others in the room might actually be recognizing. Things like a gradual drift downwards in blood pressure on the monitor, or a slow rise in the patient's end-tidal CO2 level, indicating a ventilation issue.
Is there any way for someone to recognize they might be falling into this tunnel vision trap themselves, a personal warning sign?
Yes, there's a classic one. The most common internal indicator that you might be losing or have lost, situational awareness, is the distortion or loss of time perception.
Losing track of time.
Yeah. When a surgeon suddenly realizes, maybe prompted by someone else, that 45 minutes have passed since the last time they mentally checked the overall patient status or the progress of the operation, and it only felt like maybe 10 minutes. That's a huge red flag. They've likely been deep in the tunnel.
Which is another reason why those regular breaks or check-ins are so important.
Absolutely. They force you to pull back, look at the bigger picture, recalibrate your SA, and check the clock.
The source material draws this incredibly powerful and frankly devastating parallel between an aviation disaster and a medical tragedy that shows how exactly the same cognitive trap, this loss of SA, this fixation, can be fatal, regardless of the specific high-stakes environment.
Yes, this parallel is essential for anyone striving for mastery in this area because it drives home that these are fundamental human failings, not specific professional ones.
Tell us about the cases.
Well, first, consider the tragic medical case mentioned earlier.
Right.
A healthy woman undergoing a routine ear, nose, and throat procedure who died because of a failure to intubate. The team involved was competent, experienced.
Right.
Yet, as the intubation attempts repeatedly failed, they collectively lost all situational awareness. Minutes ticked by. They became completely fixated on the single problem getting the airway device in that they failed to recognize or react effectively to the overriding critical crisis. The patient was becoming profoundly hypoxic. They
Yeah.
were missing the big picture because they were stuck on the micro problem.
Okay. And the aviation parallel, recognized by the patient's husband, who was an airline pilot.
Yes, chillingly. Her husband immediately recognized the pattern. It mirrored a well-known fatal plane crash from years before. In that crash, the entire cockpit crew became fixated on troubleshooting what was actually a relatively minor, non-critical technical issue,
Mm-hmm.
a faulty landing gear indicator light.
Just a light bulb.
Essentially, yes. They became so intensely focused on diagnosing and trying to fix this small, immediate problem, using up all their collective mental bandwidth, that they completely failed to monitor their primary systems, crucially their fuel levels.
Oh, no.
The result, the aircraft literally ran out of fuel and crashed, killing many on board, simply because the entire crew was collectively tunneling on the landing light amidst the macro existential crisis unfolding around them, plummeting fuel gauges.
It's exactly the same cognitive failure.
Identical. In both the OR and the cockpit, you had competent, experienced teams who became fixated on a micro problem, lost situational awareness of the bigger picture, failed to communicate effectively about the overriding threat, and allowed a preventable disaster to occur.
That story really underscores the point that these aren't surgical failings or aviation failings. They are human cognitive frailties that can manifest in any high-pressure, complex environment,
Precisely.
which surely means that this kind of human factors training, focusing on SA, communication, teamwork, it needs to extend far beyond just the traditional operating room, right?
Oh, absolutely. Think about the rise of complex, minimally invasive procedures happening outside the main OR now. Interventional radiology suites, cardiac cath labs doing percutaneous coronary interventions, complex GI endoscopic resection.
All high-stakes, complex procedures.
Exactly. They often involve sedation or anesthesia, complex technology, multidisciplinary teams, and carry significant risk. The potential for communication breakdown, loss of SA, and team dynamic failures is just as high, if not sometimes higher, if the teams aren't as consistently working together as an OR team might.
So HF training is relevant everywhere.
Everywhere invasive procedures happen. And the beauty of HF training is that it's relatively simple, it's cost-effective compared to buying new technology, and it's inherently egalitarian. It engages all staff members, nurses, technicians, doctors, trainees, consultants, focusing on shared principles like safety leadership, fostering that open culture we talked about, and embedding regular safety briefings and debriefings into the workflow.
The goal being?
The goal is a persistent, proactive influence on the team's attitudes and values regarding safety, making safety not just a protocol, but a core professional value for everyone.
Okay, we've covered a huge amount of ground. We've built the foundation from the organizational culture right down to the individual surgeon's physiology and emotional state. Now, to really achieve that mastery we aimed for at the start, we need to synthesize all this into a clear, actionable checklist, a how-to guide for elite performance based on everything we've discussed.
Absolutely. Let's frame these as the kind of required professional standards, the non-negotiables, for achieving optimal human performance in any high-stakes medical setting. These are the concrete actions that help mitigate the risks we identified using the HFACS model.
Great. Let's start with preparation. This is about addressing those layer 3 preconditions before you even walk into the theater or procedure room.
Right, preparation. This is fundamental. You must consciously ensure you've had adequate rest, ideally 6 to 8 hours of quality sleep. You need to integrate regular physical activity into your life, not just for physical health, but for mental resilience. And crucially, ensure adequate complex nutrition before undertaking demanding procedures.
Fueling the machine.
Exactly. This is mandatory for achieving optimum alertness and cognitive function. And as part of preparation, proactively check your own HLT factors.
Hmm.
Am I hungry, anxious, late, tired? And keep an eye out for those signs in your colleagues too.
Okay. Next up, the checklist and the mandate around communication.
Yes, the checklist rule. This needs to be absolute. Never, ever use only part of the WHO checklist or your local equivalent. The data shows outcomes are worse with partial compliance. You must mandate reading it out loud, fully, with visible, audible, verbal participation from all key team members. No exceptions. This is about professional discipline.
Got it. And communication.
Communication. Two key things here. First, adhere to the sterile cockpit principle during agreed-upon high-risk phases. Prohibit avoidable interruptions and distractions and non-essential chat, phones, etc. during those critical operational parts. Second, mandate positive closed-loop communication,
No.
meaning confirming that the message sent was actually the message received and understood, especially during handovers of care or when giving critical instructions or medication orders. Readback is a simple example.
Okay. What about personal monitoring during the procedure itself?
Personal monitoring and breaks. This comes back to acknowledging that 20-30-minute concentration limit we discussed. You need to schedule, or at least allow for, regular short recovery breaks, maybe 10-15 minutes every 2-3 hours during long, complex procedures.
And look out for each other.
Absolutely. You must look out for yourself, monitor your own HLLT factors throughout the case, but also proactively monitor your colleagues for signs of fatigue, tunnel vision, or loss of SA. And critically, have the courage to intervene assertively but respectfully when you spot those signs. Hey, looks like you might be getting tired, want me to take over for a minute? Or can we just pause and double-check the overall picture here?
Ergonomics often gets overlooked, doesn't it? But it's mentioned here.
Ergonomics and comfort. It seems minor, but it's such low-hanging fruit in terms of safety. Do not force yourself or your team members to assume physically uncomfortable postures for prolonged periods unless absolutely necessary. Take the extra 30 seconds to adjust the operating table height, the monitor position, the lighting, for the comfort of the entire team. Physical discomfort directly contributes to distraction, fatigue, muscle strain, and ultimately increases the risk of error.
Makes sense. Now, culture enforcement. This feels like the responsibility of leaders.
Culture enforcement, yes, primarily leaders, but everyone plays a role. To prevent that systemic rot we saw in layer 1 and 2 failures, you absolutely must not tolerate toxic, belittling, or bullying conversation within your theater or department, period.
What should leaders do?
A leader must immediately, consistently, and visibly shut down that kind of behavior because it directly creates a chilling effect. It destroys psychological safety, prevents people from reporting hazards, and stops staff from speaking up when they see an error about to happen. It undermines everything else we've talked about.
Okay, final point on the mastery checklist. Proactive recognition and rules.
Proactive recognition and roles. This is about mindset and planning. Always be prepared for the unexpected, for deviation from the plan. When leading a team, it's not enough just to introduce everyone and say, speak up. You must explicitly define specific roles and responsibilities for potential complications or emergencies before you start. Everyone needs to know their immediate action step when something goes wrong.
And keep learning.
And continuously learn. Employ structured debriefs after every significant case or event. Track relevant patient safety metrics. Use that data not for blame, but to proactively identify trends and areas for improvement. It's about building a learning system. #outro. So that really brings us to the end of this deep dive into human factors. I think fundamentally the appreciation of all these elements, the team dynamics, our individual cognitive limitations, the massive impact of organizational culture, these are now absolutely non-negotiable foundations, not just for patient safety, but for true professional excellence in medicine. Hopefully, we've provided you with a solid framework, some clear models like HFACS and Swiss cheese, and practical tools to really master this information. It's about applying these structured, often hard-won, life-saving lessons from other high-risk industries to every single aspect of our medical practice.
Absolutely. And if we just circle back quickly to that Swiss cheese model one last time, remember, the disasters, the really bad outcomes, they're rarely caused by just one single isolated error.
Almost never.
They require those multiple factors, the organizational weaknesses, the supervisory gaps, the preconditions like fatigue or distraction, and finally that unsafe act. They all have to align just so. You now, hopefully, possess the awareness, the models like HFACS and actionable tools, simple things like HLLT or the sterile cockpit idea, to actually recognize those holes before they ever line up.
And crucially,
And crucially, the understanding that you have the permission, perhaps even the obligation, to disrupt that alignment, to be the slice of cheese that stops the trajectory of error.
which leads us, I think, with a final, perhaps provocative thought for you, the listener, to take away and consider, especially given those stark statistics we started with about preventable harm.
Go on.
If avoidable patient harm remains one of the leading causes of death globally, what is the moral imperative then for every single professional in that room, regardless of their role or rank, from the most junior student to the most senior consultant, to actively challenge the status quo when necessary, to assert their concerns even when it feels difficult, recognizing the system failures laid out in HFACS, understanding SA, knowing the power of communication? This knowledge makes you a crucial final safety barrier.
Use that knowledge.
Use that knowledge. Use your voice. Protect your patients and protect your colleagues.